All right, well, welcome everybody. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from the what to the why. Knowing the why matters because when you know why you do what you do, it changes the how, even on your exams. You know, it's crucial for all of us to move beyond typical topics in medical education and concentrate on something equally important for your long-term success. Understanding the why behind what we learn and mastering its application by practicing high-yield, multiple-choice questions that you would likely see on your exam. So this topic focus is focused on a practice question related to the area of infectious diseases and specifically pneumonia. Now you may be asking yourselves, why? Well, because pneumonia, and you look at a lot of diagnoses and the top drugs prescribed and the top diagnoses that either are treated in the outpatient or inpatient environment, those are questions that show up on your exams or boards. So it's important to have context. So what is the context of pneumonia? Well, every year, millions of adults in the United States develop community-acquired pneumonia, also known as CAP, one of the most common and deadly infections we face. In fact, pneumonia is one of the leading infectious disease causes worldwide. Community-acquired pneumonia accounts for approximately 4.5 million outpatient visits annually and leads to more than 1 million hospitalizations in the United States alone. Now, mortality isn't trivial. That's why we give it attention, why it has guidelines. Among otherwise healthy outpatients, the death rate is around less than 1%. But for those that get hospitalized, it jumps up from between 5 and 15%. And for patients who get admitted to the ICU, that can soar to above 30%. So who's at risk? Well, remember guys, older patients, typically over the age of 65, people with chronic medical conditions like diabetes, COPD, heart failure, and anyone with impaired immunity. But don't be fooled. Even healthy middle-aged adults can still end up in a hospital with community-acquired pneumonia, especially during the flu season. So the real question isn't if you'll encounter pneumonia in your clinical career, it's how well prepared you'll be to recognize it early, treat it effectively, and improve outcomes for those patients. So let's dive in to a practice test question that you might see on your exams. Okay, so we have a 54-year-old male who comes into the emergency department with a 2-day history of fever, chills, productive cough with the productive sputum that's yellow in nature, shortness of breath, intermittent confusion. His past medical history does include heart failure with reduced EF, hypertension, and type 2 diabetes. He has no reported recent hospitalizations or antibiotic use. On exam, his temperature is 39.9, roughly about 103.8 degrees Fahrenheit. Blood pressure is 128/76, so he's maintaining some hemodynamic stability. Pulse is 102. Respiratory rate is 24, and oxygen saturation is 90% on room air and at rest, so not with exertion. Crackles are heard over the right lower lung field. Chest x-ray shows an infiltrate in that area. So which of the following is, here's the stem of the question, which of the following is the most appropriate empiric treatment for this patient? Okay, your first answer choice is azithromycin monotherapy. Next is ceftriaxone plus azithromycin. The third answer option is piperacillin tazobactam plus vancomycin. The fourth question option or answer option is levofloxacin monotherapy. And a fifth option, which is not always normally the case in most multiple choice questions, but I wanted to bring it up here, is amoxicillin alone. Okay, so at this point, you didn't get a diagnosis. It didn't say the patient is being treated for pneumonia, okay? But the pattern of association in the question leads directly to that diagnosis, right? So that's the underlying presumption. I think most of you probably got that right. The question that you need to answer now is really based on the fact of, am I treating this patient for community-acquired pneumonia in the inpatient or outpatient environment? Okay? And the correct answer here is ceftriaxone, or the best answer here is ceftriaxone plus azithromycin. Now, let's go through and break down the question and look at some of those core clinical clues. Okay? Now, we've given you access to the case so that you can have that. For those of you that want it, there is a download for it so that you can take notes if that is helpful to you. But if you look at the case, the patient has a fever, productive cough, shortness of breath, focal or localized crackles on exam, a chest x-ray demonstrating consolidation. All of that is consistent with a pathophysiology, clinical presentation, signs and symptoms of community-acquired pneumonia. What about sepsis? So do you know and understand the SIRS criteria? Do you have to know it? Well, there are some SIRS criteria that are present here. The patient has a fever. That's number one. Number two, the patient's pulse is over 90 beats per minute, which meets the second criteria. So if you have two or more of the SIRS criteria and you have a known concern for infection, like pneumonia, that would technically meet some of the criteria for sepsis, right? It even warrants the idea, even if you didn't technically want to call it sepsis, to get cultures in these patients because the risk of bacteremia is definitely higher, okay? What about modifiers that guide us that treatment, right? So the patient's age is over 50. He has comorbidities of heart failure with reduced EF, diabetes, and hypertension. So you're stacking these comorbidities, and as I presented at the beginning, these patients tend to be at higher risk for complications. Now, he's not been recently hospitalized, so the risk of having exposure to obvious or apparent MRSA or even Pseudomonas is not likely there. That's what eliminates some of the other options that we'll come back to in a second, and the answer choices. Now, what about his O2 sat? It's at 90%. Technically, right there on the edge. Most people, like if he exerts himself at any degree, which you don't have any information that he did, but if, again, understanding the disease, that's what they're trying to test you on as a core concepts and applying it to pick the right treatment for the right patient scenario. This patient with a little bit of exertion easily falls below 90%. Now they're needing some supplemental O2 if they even try to move, right? That's not somebody you're going to send a patient home. So this patient requires and would benefit from hospitalization. Now, how did we determine that? Well, there are two tools that you should be familiar with and is assumed in this question at some level that you are aware of if you understand the basics of the disease. So we use risk stratification tools to place patients in a risk category. Are they high risk, moderate risk, or low risk? Because we want to send patients home and keep them out of the hospital if they're at low risk. But if their risk for mortality goes up and reaches a certain threshold, then we should probably give them consideration from admission, even if it's an observation admission. And the CURB-65, along with the Pneumonia Severity Index score, which is historically known as the PORT score, are tools that clinicians use to decide, is this an inpatient or is this an outpatient situation? Now, can you discern some of that? Well, you can, even without doing the whole scale, right? So let's go back to this patient, and then I'm going to cover for you some core knowledge about CURB-65, PSIs, What does a chest x-ray look like? So that you learn some of those core concepts that are understood and being taught. Because listen, guys, no one has the questions to your exams, and if they do, something's wrong, and they're probably going to get caught, and it's unethical and unprofessional. But if you're taking a board exam, it doesn't matter that you don't have the questions. No one does. You need to understand the core concepts and why the correct answer was the correct answer and why the wrong answers were less desirable or not the best answer. That's what you need to know, because if you can do that, you can apply this information to anybody any case or question that you receive. It's also clinically applicable and relevant to real-world practice. So you're learning something as we do this practice test question. So azithromycin monotherapy would be appropriate for somebody in the outpatient environment who's otherwise healthy, not many significant comorbidities. Piperacillin and tazobactam combined with vancomycin, well, those are some big guns. Piperacillin and tazobactam, pretty broad spectrum, also not only covers for some anaerobes, but Pseudomonas. And then you have vancomycin, again, parenterally administered for MRSA. Well, remember, that's why we were looking for risk factors. So that would be people with suspected hospital-acquired pneumonia, or patients from a nursing home or a care facility where the risk and exposure is higher to those organisms. All right, so what about levofloxacin monotherapy? It's definitely an acceptable alternative, but it's not the preferred, right? You'd only really jump to that big gun, broad spectrum antibiotic, covers the typical agents, atypical agents, some anaerobes, right? We would jump on that if someone really had a contraindication or an allergy to beta-lactams and macrolides, but that's not the case here. So we would typically reserve that as backup for that situation only. What about amoxicillin alone? Well, it's not sufficient for inpatient coverage. Why not? What is it lacking? Well, it lacks atypical coverage of bacteria. Those are going to be things like chlamydia, Legionella, mycoplasma. Those organisms are not going to be adequately covered and without having atypical coverage. That would be your macrolide antibiotic, or like the levofloxacin could cover that in the situation. Now, amoxicillin, on the other hand, if you have a pediatric patient with community-acquired pneumonia, it is one of the first-line treatment options to give consideration, especially in the outpatient environment. So don't forget that for your pediatric population. We're dealing with someone who's a little bit older, so it's obviously different, but I wanted to make sure to kind of throw in that point. All right, let's take a moment and go, well, what is right-sided or right lower lobe pneumonia? Well, first of all, I don't have time to go through all the aspects of reading a chest x-ray, but this is a standard anterior-posterior chest x-ray where you can see some area of consolidation here. If you just compare it to this dark area over here on this side, right, this is supposed to be at the same level of darkness here, but it's clearly not the case. So you can see a little bit more density and haziness in that area. That would be the right lower lobe. The right middle lobe is kind of in this area, and then the right upper lobe is here. The left lung only has two sections. So the right lower lobe, that would be indicative of what that would somewhat look like. Now, when you are answering questions related to pneumonia, specifically, you heard me talk a little bit about where I treat. The setting is important, and that's related to the disposition. So even if a patient presents to you in the clinic, you have to make the same decision. Do I call an ambulance, or do I admit this patient directly from my office to the hospital or send them to the emergency department? Or if they're in the emergency department, where do I do with them? Do I send them home, or do I admit them to the hospital? It doesn't matter what environment. That can happen in both places. You have to factor in those comorbidities, and that's where those risk stratification tools come in. So we have what is called the PSI, or Pneumonia Severity Index, also known as the PORT score, okay? Now, this is an example of what it looks like, okay? It's very complicated. I do not believe for 1 minute that you need to memorize it. I wanted you to see it. One of the reasons why we use Curb 65 is because this is very involved. It requires technically an ABG, labs, and all this stuff. Sometimes that's not accessible to us. But I want you to pay attention to one thing that's right here. If you look at the age of the patient, and our patient was male, you start out with a number of years of their years, right? So if you're 55 years old, you're starting at your port score is 55. If you're at 60 years old, it's 60. If you're 70, it's 70. Now, if you're a female, you subtract 10 from that number. But that's your baseline just based on your years. So the older you get, the more risk of mortality that you have. And that goes back to what I was saying earlier, okay? Now, if you go through here, you see that add 10 points if you're from the nursing home. If you have cancer, if you have liver disease, congestive heart failure, our patient had that, right? Altered mental status, there was a report of intermittent confusion, okay? That would probably qualify, so you have an extra 10, that's an extra 30 points right there. So now we're up into the 80s on this patient's port score without even doing all this other stuff. Patient has a temperature, so you add another about 15. So now you're close to 90 in the number. And again, I still don't have labs. Do I need them to make this decision? No, I don't. I just know that from the basics, and I can tell you that the patient's score is above 70 at this point. And so when you do that and consider the risk of mortality, that's when the risk changes, okay, from being less than 1% to now greater than 2%. And then it certainly increases as you go down or increase the number of points in the port score. But you see here, once you get above 70, you're asking the question, or they're wanting to test you to discern, do you know that you need to make that decision? Well, what was the tipping scale? Well, one, the patient started to meet SIRS criteria. Well, it did meet SIRS criteria concerning for sepsis. That would be high risk. It's considered a medical emergency, number one. Number two, his O2 sat without exertion at baseline on room air is 90%. So he's probably going to be hypoxic with any exertion. That's not going to be good with somebody who has known heart failure, has hypertension, diabetes. These comorbidities start to get out of control and they start to spiral. So now this can be clinician specific. It can be done in shared decision making with the patient, but in most cases, this patient is obviously going to meet the criteria for being admitted to the hospital. Now, the PSI or port score is very convoluted and difficult. And that's where the Curb 65 was developed. Curb stands for C for confusion. Our patient had that. U is uremia, a BUN greater than 20. I don't have that information. Okay. Respiratory rate greater than 30. His was not, okay. Blood pressure, systolic blood pressure less than 90. His was not, okay. And he's over age 65. So in this case, you'd go, wait a minute. His risk is basically 1. Well, we don't know what his BUN is, right? That was a question mark. But right now, the patient, so why did I do this? I wanted to show you how sometimes a scale or tool is meant to be a tool. It's a guide. It's not perfect. It doesn't always align. That's where your clinical experience, your gestalt, or the other pieces of information put a pattern of association together that allow you to understand the disposition of this patient. Okay? Now, are you required to do this to understand that? No, but I'll tell you that the question that was asked assumed that there was some context about these decisions that you as a clinician taking the test, answering the question, had to make. Now they tried to get rid of there's also a CRB 65, which basically eliminates the U. So all you need is 2 points, and you're considering inpatient or outpatient. So any one of these others, so if the patient was over 65, plus a little bit of intermittent confusion, automatically being considered for admission, the mortality is starting to rise, okay? So it's a helpful tool, just like PSI, but they have their limitations, they have their issues, and that's okay, as long as you understand that. And I wanted to make sure that you see it being applied and why sometimes it's not always perfect. Okay, so as we kind of wrap things up on exams, those two details often reflect the deciding factors that separate a narrow spectrum outpatient antibiotic regimen choice from a broad spectrum empiric inpatient regimen. So if you see things like comorbidities like diabetes, COPD, heart disease, you generally probably need to pause. It's a red flag. They're telling you something. It may likely end up being those patients need to be admitted to the hospital, especially in the context of pneumonia, because one disease exacerbates the other. And those patients then need a broader spectrum of coverage because they're sicker, okay? And that simple check can help you to eliminate distractors fast and zero in on the right answer. Well, I hope that you found that question and additional teaching point and core content helpful. I'm Dr. Busti, and this is why we're here, to invest in each other by helping healthcare professionals understand the why so that you can master the how, even on those tests that we have to take. All right, take care, guys.